Greetings. This is Graham Warren working with you on a brief introduction to the hip op case. This case deals with hip and knee replacements at a fictional hospital by the name of Hipkins. And there are two KPIs of interest here. The first is the number of surgeries being completed in a day at this hospital, 4 to 5 typically. These are total hip and knee replacements, so THAs or TKAs. And the concern here is that these numbers are low relative to what surgeons in private practice are achieving. So, sometimes in the ballpark of 8. So they're doing roughly half the number of surgeries, and they're looking to improve this. The second KPI of interest is related to patient well-being. So we have patient flow times, which are measured from the time that the patient arrives to the time that their surgery completes. They're still going to go on to recovery, but to the point where the surgery wraps up. That is, we consider the flow time, and we're looking to minimize that to reduce anxiety on the part of the patient waiting, before the procedure, as well as patient's family and friends who are perhaps waiting at the hospital or for a phone call about the outcome of the surgery. So we're looking to minimize that, and there's a tension here. Well, not a tension, but they're competing objectives with regard to profit from the number of surgeries, as well as working to maximize patient well-being. So there's some background information on these procedures, some demographic information. One of the key things I think that we should note, these images here were used with permission. So here's what's happening in a knee replacement, and this is what's happening in a hip replacement. One of the key levers for this paper originally was this observation by Penoja, one of the co-authors of this case, and his co-authors, that the body mass index of patients is a good predictor of the time of surgery, as captured here. So you can see for these different BMI categories, underweight, normal, overweight, obese, and morbidly obese, you've got increasing times. And we're going to elaborate that a little bit, in another table further on in the case. But there's a question here as to whether taking advantage of this BMI difference is, something that we can exploit operationally. So there's additional demographic information here, but let's look at the surgery process in a nutshell. We're not going to distinguish, the type of surgery. It could be a hip, could be a knee replacement, and we're just considering these all surgeries. There are 2 tracks of ORs, 2 ORs in each. So track A and track B, each with 2 ORs. And we schedule 7 patients in each, arriving at 7:30 in the morning. And then these folks, keep coming with the day ending at 6 p.m. The drama is, if a patient is scheduled late in the day and is unable to receive surgery, then they get bumped to the next and may actually have to come back in, or would have to come back in. And, this disruption and, the dissatisfaction that is associated with it is just not something we want to have continue. So if we can get 7 surgeries reliably complete, that would be a great outcome, while simultaneously minimizing patient flow time as much as possible. So with regard to that, the differences by BMI, you can see here are those BMI categories. Here are the procedure times that are taken directly from the paper. Here, those are the median times. We're just going to assume that they're average times here, and then there's some standard deviations as well that increase as BMI goes up. And you can see the fraction of the procedures that are, they're executed on these, performed on these different BMI categories. Okay, so what does the process look like? They come in, they get registered, and then there's a consent process, and they get sedated, and then they receive their surgery. And at that point, from the time of arrival to the end of surgery, we call the flow time. From there, they go to recovery, and some of them, go home, and some of them go to the hospital and some of them go home a day after they've been in the hospital, and some of them, more than that. But that's the essential process. Once the surgery is complete, the patient goes to recovery. The EVS staff come in and they clean and sanitize and restock the ORs. So what is entailed in this case is we're looking for process innovations. And we're going to work with an AnyLogic model to explore things like changing the number of anesthesiologists available in the workflow, number of surgeons perhaps, or physician's assistants, looking at whether we're going to pool some of these resources, if there are any innovations, perhaps through robotization or lean techniques, or however they come. We're looking to exploit these to get ourselves to the point where we're able to deliver 7 surgeries per track, maximizing profit and minimizing flow times for patients. So we've got some further data here related to the workflow. So the registration takes 15 minutes on average with a standard deviation of 2 minutes. That pre-op prep and consent, we're going to call 25 minutes with 5 minutes of standard deviation in each. Then the procedure itself, 100 minutes, 100.71 minutes on average with 809 minutes standard deviation. And then that cleaning and so forth, 40 minutes with a 5 minute standard deviation. And then recovery, which is not of interest really in our flow time calculations, takes 20 minutes on average with a 50 minutes standard deviation. And then there's a discharge potentially, or folks go on to the hospital, but neither of these last two are going to be factored in our simulation model, because we're looking at the flow time only from time of arrival to completion of surgery. All right, so there's 4 lenses that we could use to surface ideas for improvements, and in the playlist that further on in the playlist, you're going to find some suggestions for types of process innovations that could be contemplated, and then the challenge is to sort of price these out, reflect on them to decide whether they are medically feasible, desirable, and in which combination you want to recommend them, as a basket of improvements to overall hopefully deliver the surgery counts that we're looking for, and the flow times hopefully at a minimal level. So the 4 lenses: does utilization matter, does pooling matter, does variance hurt, and does psychology matter? I think the flow time clearly connects to the psychology matters piece, because you've got friends and family in the waiting room or waiting for a call, interested in the outcome of the surgery. So there's some supplementary questions here for you to consider, and you've got some ideas here related to standardization, maybe robotization, and so forth. And you are free to explore journal articles, leverage experience, white papers. If you can back up proposed improvements with and argue that they're feasible and sustainable, go for it. I'm looking forward to hearing what you have. And so here is a quick shot of the AnyLogic model, but I'll pick that up in the next clip with a discussion of the base case.